We're going to start at 5 minutes past 6 because we're still waiting for a couple of people to join in and for people to log on to YouTube, I think. Yeah, and can you please have our speakers turn on their cameras if possible? Thank you. Is everyone okay? Can we start now? Okay. Good evening, everyone, and welcome to our intersocietal public versus private. Thank you to all our viewers on YouTube. I'd like to send a warm welcome to our speakers tonight and to thank them for taking time out of their busy schedules to be with us this evening. I hope we'll gain a lot of insight on the different sectors of healthcare in our country and possibly their journeys in healthcare. I'll be co-hosting with Marcel. He'll be helping me with a couple of questions we have received from our audience. So yeah, on our panel tonight, we have Dr. Argentina Ingrata. She is a physician specializing in internal medicine at Helen Joseph. We also have Mr. James Kambaki, who is the head of HR in fieldwork in MSF, which is Doctors Without Borders. He was also involved in the Ebola outbreak in West Africa and is also involved in natural disaster and HIV/AIDS management. Last but not least, we also have Dr. Cherie Koenen, who is a qualified plastic and reconstructive surgeon with special interest in pediatric and breast reconstruction. Thank you once again to our speakers. So I think we should start with our questions. The first question we have is, what are your views on the state of healthcare in South Africa, especially during the pandemic? I think any one of the speakers can start.
Hi, everyone. Thank you for having me this evening, and to our co-speakers. As your colleagues mentioned, I work in state, and the interesting thing about the COVID pandemic is it really highlighted the deficiencies and the ailing parts of our healthcare system. And it really brought to the fore the problems that we have there. But it also allowed us to work together as teams in a way that we hadn't done before. And I think that there's a lot of benefit in that. So there's a bit of good and a bit of bad, but that's from my perspective.
So from my perspective, it was actually quite interesting because I'm only recently moved to private practice. I was in government practice for quite a while before that. So during the first wave, I was still in government at Charlotte Matseke. And during this past third wave, I had moved recently to private practice. I think we all know that the difference between public and private is very discrepant. But what was interesting for me to note is that during the third wave in private, when the healthcare system was pressed in a way that potentially it had never been pressed before. So in private, it's quite different in that if you want an ICU bed, there invariably is one. If you want something, there is something. And I think this was the first time many doctors that have been in private practice for many years were in a position that they were potentially in when they were last in state, where there wasn't everything for everyone. There weren't beds in a lot of the hospitals. There weren't resources there. And I think that was quite an interesting thing for me to see, having just come from where we used to always being in that position. And it really showed me how discrepant it is that when there isn't everything that you could possibly want, it was quite a different experience for a lot of the doctors that have been working in private practice for a very long time.
Yeah, I think in our perspective, Doctors Without Borders, is that we have never been prepared enough for such a huge pandemic. And that goes all the way, Western countries, to many African countries, Asian countries, and including South Africa as well. We have the facilities and the healthcare structures has not been prepared enough for such a huge pandemic. And that's why also, including Doctors Without Borders, we have not been well prepared for it. It's huge. it has caused a lot of strain, and not necessarily because there was possibly either not enough staff, not enough ICU beds, not enough. We were just not prepared. Nobody really anticipated that such a huge thing. And lessons learned there is that we should definitely take advantage of such events or such a pandemic to prepare even better. So to invest a little bit more in health as well. At the same time, we've learned a lot to partner with many other organizations. For us, Doctors Without Borders, we couldn't do it alone without the government, who are taking the lead in most of the support that we're giving, because we were filling up a lot of gaps. And then it went all the way to actually like learning how to do the basics, because the basics were often kind of also neglected in some of the European countries where we have been supporting, and also including here in Southern Africa. That basics are really important in this particular pandemic.
Thank you very much. Our follow-up question is, what challenges did each sector face during the pandemic? And I think like each speaker has somewhat touched on this. So I don't know if any of the speakers would like to answer or further elaborate on their previous question, but I feel like it's similar to the first question. So if there isn't anyone who would like to answer this question, I can go on to the next question. So the next question is, what do you wish to see in the other sector that is only found in the other sector? So basically, what do you wish to see in either the private or public sector that is only found in the other sector?
So I think what was, as I said, I've only recently moved to private practice, so it's quite a new experience for me too. And what I've realized, although it's in a completely different way, resources are what dictates what there is available in the public sector. And in private, I've come to realize that money is what dictates what you get in the private sector. So it's all centered around which medical aid, when you run out of funds, how much, what percentage cover you have. So in a way, I guess it's quite ironic that it all comes down to what resources or what financial capacity you actually have. But that being said, I think that what I'd love to have seen in the public sector is that in private, you do have almost anything that you would need available to you. And I think that patients are treated with a dignity and with a respect that I don't always see everybody in public getting. I think that it is a lot more accessible, especially in the South African setting. Should you wish to see a specialist, you can simply make an appointment with a specialist and go and see a specialist. So I think that it would be amazing if everybody got whatever resource they wanted and whatever thing they needed available to them. That would make a very, very big difference.
So I'd like to come there. I've never worked in private practice other than to do the odd locum here and there. And the one thing that I'd hoped for in this pandemic was a better partnership between private and state. And I think it became a bit of a bun fight about where to send patients. And I think that the private experience was put under an enormous pressure because they were quite used to having, as my colleague said, all the resources that they had. We had the unfortunate experience of not having enough resources and having to develop triage tools very quickly while we were learning about a new disease. And it was incredibly stressful trying to figure out which patients to put first when you have 10 patients requiring 1 ventilator, for example. And although we felt that before, we didn't feel it to the extent that we did during the pandemic. Also, the one thing I'd hoped for that didn't quite come through is in the first wave, we were all learning while we were working. And we kind of got the hang of it by the second wave. But I feel that in states specifically, we didn't really take our opportunities to make the third wave more bearable at a healthcare perspective. And I also think that I was quite frustrated with the community for expecting doctors and nurses and healthcare workers to do all the heavy lifting. And we'd hope that the lay community would take their part in play their role much bigger in terms of preventing infection between family members and, you know, limiting those things and not relying on difficult systems to get the healthcare that they needed, which was usually a last resort. So I think it was quite exhausting towards the end to maintain the impetus that the public placed on healthcare workers. And I think that I would love the public to take on a much bigger role in the upcoming waves, which I predict we will still have. Thank you.
Yeah, I think what we have seen is that the public sector really taking up the lead, which was really, really good and impressive, although there were a lot of shortcomings, and as other panelists have said, access to either the resources were completely overstretched, and we saw how the first world countries have actually like overrun other countries in actually like purchasing and using money to actually like provide only services to their population and not thinking about others. I think it's important to really consider a little bit more better the role of public sector, because I think that's where this lead has actually come and has impressed us. We as a humanitarian organization, Doctors Without Borders, we've just been filling little gaps here and there, but majority of the work was actually done by public sector, which I really want to commend in this particular regard. So investing more in public sector would possibly be the way to go. The role of private sector is still useful, but many governments that will actually look at providing universal health coverage to its population will really consider after this to invest a lot more in public sector.
Thank you. Our next question is, the National Department of Health has been having talks about the NHI, which is the National Health Insurance. What are your views on this?
Sure, I have very strong opinions about the NHI. The premise is admirable, providing healthcare to the population. The problem that I have with it is that the model was taken from highly resourced settings where there's a large tax base. And in our setting, for example, in the UK, 80% of the population pays tax, and that funds the national health insurance. But in South Africa, less than 10% pay for tax. And the thing that I think COVID taught us, amongst many other lessons, was that our government cannot be trusted with money. And it's actually disheartened me further after the pandemic, because it required the government to come to the party. A lot of funding was made available by external sources. And in the last few months, we've just seen the level of corruption that's come through. So for me, the funding perspective is a huge thing. And also the healthcare workers, in terms of the right people in the right place. I think there's a disproportionate amount of healthcare workers working in private for their reasons. And they, you know, you're looking at different ratios between a private practitioner and the population they serve versus the public practitioners and the population they serve. So I still think the NHI is a good idea, but a pipe dream in our country. And until we fix a whole bunch of things, particularly at government level and government spending level, I still think it's going to remain a pipe dream.
I have similar views to my colleague who just spoke. I think in principle, it's a brilliant idea. And I think all of us will 100% agree that we wish in a perfect world, everybody got equal access to everything, excellent healthcare, everything that they could possibly need. But again, as you said, being modeled on the Canadian system, which is really not representative of our population, looking at, even if we don't look at COVID, if we look at government-run organizations, SAA, ESCOM, I don't think I need to say anymore because we know what a disaster they are. So as much as in principle, I think it's amazing, I don't know if logistically and practically how it would actually translate to being something that is beneficial and efficient for everyone.
Yeah, I do not have a clear stand of my organization on this, the insurance issue. But what I know of our organization is that we are there to offer free healthcare service to all, especially the vulnerable population. So anything free we will definitely support in that particular regard, because we believe every individual should have access to healthcare. We save lives, we alleviate people suffering. So this is what we will definitely want to support. Personally, I think that, and I agree with my two panelists also who have spoken ahead. Personally, I think that copying and replicating services from countries that have already have a system that is really well running is really a misplaced kind of idea to go. But if a country like this could actually showcase a different model for also including other third world countries, I think it would be really useful, not only for South Africa as a country, but for Africa as a whole, that there is a different model where populations of this particular continent, where there is low investment in health sector as compared to other departments of governments across Africa. There is low resources in all the health sectors that work. So in case of any epidemic, in case of any disaster, usually public health is overrun so quickly. So if South Africa could actually take that role in modeling a service that would be much more appropriate for its population, I think that would be the best way to go. That's my personal view.
Thank you so much. Our next question is a bit of personal, but would really appreciate it if you could answer it. The question is, if you were to choose between the two sectors, which one would you go for? Why or why not?
I don't mind to start. I actually wouldn't have moved to private practice if there were consultant posts available in plastic surgery. At the time, I loved working in state. I loved working in government. I was very happy. So me moving to private was not really a choice. It was more just a natural progress because there weren't any consultant posts available at that moment in time. We're quite a small department. But the things that I am really loving about being in private is that you have power to make a difference, and you're not as reliant on a system to give you those kind of opportunities. So for me personally, I enjoy that I'm responsible to a major extent for my patients' care, and I'm responsible for following them up, and I'm responsible, and I kind of get to follow them all the way along their path from their first consultation through everything, through their surgeries. As they said in the beginning, I do mostly breast cancer reconstruction and pediatrics. So I get to see my clefts, and I'll continue to see them on and on and on. And you get to see your same patients. If I want to, if they need anything, the resources are all available. You can surround yourself with whichever team you choose to surround yourself with. And for me, that type of work environment where you can build something that you feel is something excellent, and you can offer a service that you feel you couldn't possibly provide this patient with anything better, and it's within your power to do it, is very rewarding for me. And so that is probably the part that I like the most about private. But part of me really misses the patients in public. I do miss that, you know, just knowing that you are just making such a huge difference to each person. And yeah, I don't know if I can honestly and truthfully say that one is better than the other. I think there are pros and cons to both. And for me personally, I like aspects of both. And so I wouldn't ever say I'd never come back to public practice. So I don't know. I think there's good in any situation you find yourself in. I guess it's just the way you choose to see it and experience it.
I think my colleague raised a lot of really important points there, but the main reason that I've remained in state is twofold. One is I chose a specialization, which was medical education. So I'm both a physician and a medical educator. And I haven't got experience teaching in private, but it is one of the main reasons I stayed in state. Because I tried for many years as a physician to change the system, and that was very frustrating. So I opted to rather work with the trainees and see if we can improve their training so that they can help us change the system. I love to teach, and our state patients are special, and my colleagues touched on this, because they really have no alternative, and providing them the best level of care, especially at an academic level, is really very rewarding. And I do think that specifically in our academic training hospitals, our patients really get the best that's possible at a state level. I just wish that it could be available to a lot more of the public. So my hope is to train clinicians that can take their skills and go further out. Unfortunately, what my colleague raised about not having enough space in state to keep all of the trained specialists is a huge issue. And so often people leave not because they want to, but because they have to. That being said, I do think that both spaces have benefits, and I often wish and pray for a better collaboration between the two spaces, because those resources that are available in private are things that we should be having access to for our patients, but also the ability to train in the way that we do in state should be available in private as well. So I think the partnership should exist much better than it does now. And I just wish that finance wouldn't separate the two like it does.
Yeah, I think definitely there is, for me personally, and I think it's good that you put there, if it's a personal idea, or I think it's really useful, especially after this pandemic, that governments are investing a lot more in public sector. And that's really the bottom line. Invest a lot more in public sector. Private sector is okay to actually coexist within that framework where investment has actually been maximized in public. I won't really wish to see a situation where a lot of consideration and efforts to actually like ensure that public sector, private sector thrive is what particular governments like South Africa and other countries will actually prioritize. That's because one, there's still a lot to be done to actually strengthen the public sector. Two, the vulnerability of the population that lives amongst these countries are really a group that needs specific attention and specific prioritization by all Ministry of Health and governments to actually like undertake to ensure that they have access to best quality health services. I fear sometimes when you have a very robust private sector, because it drives costs of healthcare so high that it cannot be, at some point, it will not be affordable to ordinary citizens. That's only the fear I have. But of course, there are positive things that comes from private partnership, private-public partnerships that actually will actually enhance possible improvement of certain quality aspects. But in any case, there is also institutions of higher learning that could actually be supported a little bit more to do that. So I would really support to have very, very strong public sector. Of course, there should be room for private sector to coexist with them, but not to surpass and to thrive much more bigger than private public sector.
Thank you so much. Our next question has to do with mental health, especially with regards to healthcare workers. The question is, in the past year, what interventions have been put in place to improve the mental health of healthcare workers?
I'll go first. Mental health has become a massive issue in my space. And what we're finding is that doctors, you know, when with the first wave, we were carried, we had a lot of support, and it's not that the support has waned, but the duration of the pandemic has just become too much of a burden. And in fact, whilst we saw us getting better at handling COVID, our doctors and our colleagues struggled with mental health much more than on a scale I've ever seen before. In fact, simultaneously, we also had a massive increase in psychiatry patients admitted at my hospital specifically. And I think that mental health issue is a pandemic-related issue, but for healthcare workers, it was magnified because of repeated and lengthened periods of stress that never really let up long enough for people to recover. And in fact, there was also a demand, you know, certainly in my space, for things to return to normal as quickly as possible between waves, not just in service delivery, but in training and teaching and all of those elements. And it just feels like we're in a wave and we keep getting knocked down. And then just as we stand up, we get hit with another wave and we haven't had an opportunity to recover. So what we've done is we've identified a lot of people with issues, but has anything been put in place specifically for this? We've never dealt with mental health well in the healthcare profession at all. And I don't think we're doing any better now. We've just got a lot more people that are unwell. But I think that the empathy's run out quite a bit at colleague level and everybody is stretched. So I would love for that to be dealt with a little bit better, but in my opinion at the moment, it's a massive gap.
I'm not aware of anything in the private setting. I mean, my practice is owned 2 of the big hospital groups, you know, of the 3 big hospital groups. So I'm not familiar with anything specific or any. I think it's kind of left up to each individual in private practice to kind of take care of themselves should they feel the need to have that. So I stand to be corrected. That's just in my experience of it.
Yeah, I think it's a very, very important part that doesn't need to be neglected. We in Doctors Without Borders, we've really tried as much as possible to strengthen our focus on mental health, and especially providing that service to our staff. When we went for Ebola, we really strengthened that particular aspect, and only to realize that a lot of issues that have come from our health, from our staff, were not necessarily issues that was related to the stress and the situation that was actually on Ebola epidemic by itself, but it was more or less a continuation of certain stresses and issues that are even from the past. And in that regard, we've really tried hard to really prioritize mental health. We have actually also ensure that mental health issues are also part of our emergency response. Because initially that was not the case, that we thought only saving lives were the most important things to be done. But concurrently now in our projects, we are implementing mental health programs during that emergency phase of the project on the programs. It's really critical and important aspect. Recently during COVID as well, we had more challenges, especially in moving people. Our staff were very anxious, especially if they cannot move from the project location to go back home. We had issues of quarantine and restrictions when they are moving and how to move. That really increased a lot of mental health issues amongst our staff. And we really try to escalate and to actually provide more care for our staff, because we believe that their well-being is not only physical, but also their mental health is really important.
Thank you very much. The following question was meant for a speaker from the Bioethics Society, but I feel like we can ask this question to the panel and hopefully we can get some answers. So the question is, what are the differences in ethics in the cases you've worked on that would work a lot smoother in the opposite sector?
I think from my experience in both sectors, from a surgical or plastic surgical point of view, I don't think that there is a massive discrepancy in ethics. I think it's more that patients wait longer for their surgeries, that obviously the access to the healthcare and all the things that we've actually already discussed. But besides the distribution to everybody receiving equal care, I do feel that a lot of the ethics are quite similar from my personal experience, especially in the work that we do in our departments. I don't think that there's, besides the system and the structure, all those kind of things, I don't think that there are other major issues or major discrepancies on a one-to-one doctor-to-patient relationship that I have necessarily come across, but I'm speaking from my interaction with patients. So I know that's more representative of me than necessarily of something bigger, but I'd like to think that there isn't too much of a discrepancy. I think the only thing is to highlight that in governments or in states, you don't get to choose your doctor. So whoever you happen to see on that day or whoever you get, you don't necessarily have a choice of who's the person that is. So that for me would probably be the one thing that stands out.
I think I'm not really well qualified to answer on this question. But what I can actually attest to, based on our support to different health facilities in South Africa, especially during this pandemic, I think, I don't know if you categorize it as ethical or more compassionate situation, because the challenge has been brought by patients not actually being more alone without support, without family support, because of course of the nature of the restrictions of the of COVID. So much more patients were managed alone in institutions and in facilities, and possibly not having access to their family support or other relatives who could possibly give that, support that was there before. And so what we have done as Doctors Without Borders is try to create that community link between patients and their relatives, to try as much as possible to offer that compassionate service. I don't know if it's not really an ethical issue, but I think I just wanted to mention it here, to try as much as possible to offer certain support like that could actually make the situation a little bit more bearable. But of course, it's challenging times. You have to improvise to be able to overcome certain challenges that would possibly be otherwise, if it was not COVID, could have been managed differently.
I think for me, from an ethical perspective, COVID highlighted the massive discrepancy between a patient that has no medical care, medical health care, and has to rely on the state to provide it, versus a patient that could afford to go to private. Within the private facilities, this was my understanding. There was a very conscious, strong effort to find a bed anywhere for patients. So there was often transfer between facilities, between provinces, to facilitate patient care. We didn't have that luxury in state. And that for me was a very difficult thing to live with, because for patients, it was really luck and timing who would be able to access the very few resources that we had. And when there were lots of people, then difficult decisions had to be made by seniors about who was the most appropriate person to choose. And for me, that was incredibly traumatic. I ran a COVID team. I was a team leader. And for me, that was the hardest part about dealing with COVID, is having to make decisions that I've never had to make before, and deciding who gets to live or die because I don't have enough resources. And I think that was a really big difference between the private and the public perspective. But that also is a reflection of the fact that majority of our population does not have private healthcare. So it took that really big gap and made it much wider and brought it to everyone's attention much more. And I hope that those that have medical aid will facilitate and assist with building the public sector, because the gap got wider and COVID was very messy. And I'm not sure, I really do hope that the government learns from this and makes an effort to strengthen public, because what COVID did is it took an ailing system and properly flattened it. And that's going to stay with us for a while, I think. I just hope it will cause them pause before pushing forward with a national health insurance that they cannot fund nor staff. And I'm hoping for some sensibility from them.
Thank you very much. The next question is directed to Mr. James Kambaki. I hope I said your surname correctly. Having worked for Doctors Without Borders, what are your experiences having worked in neither of the two sectors? And if possible, how is it different from working in the South African Health Department?
I think I mentioned a little bit earlier before that partnerships for me was really key during this pandemic. That we as Doctors Without Borders, our partner has always been the Ministry of Health and governments and public sector. But we saw also there was the importance of private-public partnerships, including other organizations that came together to actually ensure that we provide certain services as best as we could. I can't say that we have not worked neither, both. Of course, we have worked more or less in public sectors a lot. Sometimes we fill gaps in different departments that we find that is overstretched, and if we don't support, the consequences of increased morbidity and increased mortality will arise. So we try as much as possible to mitigate that, but just patching up a little bit of the public sector. The issue of I think access to healthcare services is one of those that has come really at the fore, so that we know that we have not been really well prepared for such a pandemic, not really well equipped or financed to really deal with it or support the best way we could. But I think there is a lot of lessons learned that we could possibly use to actually try and mitigate if we have if this continues, or we have future pandemics as well. And I think the power of information is one of those things that I could also really pinpoint has been a big challenge in terms of either communicating the right messages to the population or the public because of certain ways that we want them to behave, the complexity that has been brought in by either political, religious, or personal intuitions that has made it maybe difficult for public to actually understand. The role of social media during this time has also been quite challenging, because a lot of information has come in, and possibly public will not be able to pick up what is the correct information to utilize and what is not. So we tried as much as possible also to develop a framework where we could provide information to the public as much as possible, which is really going to the basics. Working out through a basic structure that would actually enable a public health to be rolled out in a way that, especially in countries where there is really high tertiary quality service. Sometimes public, primary sector was actually one of those that was neglected. But we've learned a lot that partnerships between public, private, and especially private. So what we can say was, as those who have led on innovations, at some point it was kind of like a step up to actually ensure that a certain, of course, the vaccines or the drugs that are supposed to be utilized was also coming up. But the lead that was taken by governments is also something that we definitely have to commend. So we cannot say that we are in this or on that, but we think that collaborating in all the spheres that we've had, all the levels, we definitely have to enhance that particular partnership so that we can provide public health service to all, regardless of the countries they've come in, because this is another issue where those countries that were having enough resources, and we see it now the way the rollout of vaccines are happening, the hoarding of vaccines in those particular countries, and others who are still now struggling to vaccinate its population. So a lot of lessons learned. We cannot claim any trophies at this particular juncture because we are still far away from actually controlling or mitigating the pandemic. And we still have to learn a lot to actually be able to provide these services to the public in the future.
Thank you very much. Our next question is there a difference in your scope of practice in the private sector as compared to the public sector?
I'm not speaking COVID-wise, I'm speaking from a plastic surgery point of view. I don't think that there's a difference that I've personally experienced. The only thing that I would probably say is that everybody tends to very much stick to their speciality and not really overlap into too many others. So just as a simple example, say we have a pre-op patient in private who happens to be a diabetic or have hypertension. A lot of the times in government, we would have just made sure from, on our own accord that everything was stable, done, looked at our basics and all that kind of thing. Whereas in private, you tend to call in a team very quickly for everything. So if you have a patient who has any problem, you immediately call the physician, you immediately call the specialist, that specialist. So I suppose that would be the only thing that I would say would maybe be slightly different between the two in my experience, but otherwise the scope is pretty similar from what I've experienced.
Thank you. Our next question is, what can we do as healthcare workers to help the state health system to cope better with the needs of the country?
I think for me, the government, and this is my opinion, the government prioritized pushing out more junior staff as a solution to providing more healthcare to more people. The problem that I had with that is in prioritizing the interns and the community service doctors and neglecting the senior specialists and the subspecialists that were training them, they gained a lot of students and lost a lot of teachers, both to overseas and to private. And I think that the thing that I would like to see is that the government focuses on looking after the senior people, because they train the juniors. And if you leave the juniors to do their own thing, you're going to generate a population of seniors that are not having all the skills they need to continue to train. One of the things about healthcare professionals is that they're not just expected to work, they're expected to keep learning new things as developments occur in their field, but they're also expected to teach as part of that portfolio. And I think that the government didn't prioritize the correct people when they tried to ensure that there were enough people to service the government and the patients, sorry. I also think that most of the training gets done in central large cities and is not done in smaller areas and district hospitals and separate further out clinics and cities. And I think what that does is it doesn't teach people that it has merit to train there and then for stay there and provide healthcare. So a lot of people migrate to bigger areas in order to get healthcare, and instead of accessing it where they live. So that's the two things I would do. I would ensure we train enough teachers to keep training, and that we train our doctors and students in smaller peripheral sites so that they become part of the community and hopefully remain there and their skill set stays there.
I think I will advise the government to invest a lot more in healthcare, both innovation, models of care, creating scenarios of emergency response. I think a lot more investment is really required. Personally, this is not my organization stand. I think as an African, we should really invest in innovation. We have seen the way those who are leading innovation, of course, when it came to vaccines, they will definitely prioritize the countries that they actually will supply. And this will not change, because if I innovate something, I have possibly the right to supply those governments that will pay a lot more. So if Africa will actually enhance its innovation, develop its models of care, try as much as possible to think out of the box the way they could actually provide access to healthcare to its population, I think will actually be in the right direction. I will not wish that in the next 10 to 15 years that we still are going to rely on a vaccine that can only be innovated and developed in Western countries, and possibly expect to always have a sympathy, then be given vaccines and we are not investing anything. So definitely, I would like possibly many African governments to invest in the healthcare, really invest a lot more.
I don't think I'm exceptionally well qualified to answer this question, so I can only speak from my personal experience. And I think that Dr. Ngrata said about it earlier is if there's a possible way between having good public-private partnerships. So I know quite a few, and I'm speaking my personal experience in my speciality, quite a few experienced surgeons who have or asked to volunteer their time for teaching, or to come do theatre cases, or to help share the load of theatre, and that hasn't been very well received. I think it's quite a difficult logistical thing, it's a medical legal thing, it's a whole lot of things like that. But I do feel that if there was a way that we in private, now that I am in private, could contribute to assisting, to helping, to teaching, which is essentially why wherever I can, I agree to do this talk or whatever it is, even if there's one small thing or one small thing of value you can pass on to, whether it's in a teaching capacity or in a patient capacity, or perhaps there are quite a few of us who have done fellowships or have experienced that aren't necessarily available within specific hospitals, that we'd be willing to come and share that knowledge. I think that might be something that, for me, that would be beneficial, in my personal opinion.
Thank you very much. Our next question is, how difficult is it to work in the public sector but maintain some private work? I'm not sure if any of our speakers have actually done this, but yeah.
I think for me, I've been in state practice as a specialist for 10 years. And I did try to do a little bit of both. And it was impossible to split myself in two and give all that was required for the patients, either in public or private. So I think if you do that and you do it well, it's difficult to cover both groups. That's my opinion on this. And it's not an easy transition. And my co-speakers have mentioned the benefits of private versus public. But for me, I made a conscious decision to stay in public because my focus was very different to other physicians. And I think people make their choices for good reason, and that no one's right and no one's wrong. It's just what works for them, because our profession is one that you have to do for a very long time. So you have to be comfortable where you are, that you're doing the best that you can and provide the best service that you can where you are. So I think dipping in two spaces, in my experience with my colleagues who do, often the public patients suffer in that environment and the private patients are prioritized. And I think that's just because of the nature of private patients. They're much more demanding because they are paying for a service, paying a lot for a service. And I think that causes a discrepancy in how you focus when you're looking at the two spaces.
I can't comment. I've only either been fully in government or fully in private, so I have no experience with trying to straddle between the two.
Thank you. Our last question from the questions we have collected is, in what ways does the degree of accessibility differ in the sectors?
I think it's, my colleague alluded to this earlier. In state, you don't have a say who you see. It's really luck of the draw on the day that you're there. When you need to go to a particular department, you'll see who is there on the day. And if you're in a medical outpatients, you could either see an intern or a senior specialist, and it's very much luck of the draw. Also, the turnaround time and the waiting time in public is much longer than in private, and that's just an access issue. The resources are not the same, and the populations they serve are massive compared to in private. So for me, those are the two big discrepancies. I think that the level of care that is given by healthcare workers is of a similar standard, but the facility in which it's given is not quite the same in terms of cleanliness and resources and a few other things. Thank you.
In my experience in private, your accessibility is, you can, if you've got, basically it all comes down to what funds you have. If you've got funds, you can access any specialist you want. If you go to one and you don't like them, or you don't like or you want a second opinion, a third opinion, whatever it is, you have complete access to whatever it is you like. And the waiting times are minimal to get access to it. So I think it's completely different when it comes to access and timing. I don't necessarily think that the quality of the care from the doctors or the sisters or, the healthcare team is necessarily different, but definitely the access. I think for a lot of patients, what I noticed, the difference in private, you make an appointment and you go to your appointment on your day, on your time with the specialist of your choice, as opposed to necessarily having to go through what a lot of our patients do in government, where they start at a clinic, then get referred to another hospital, then get referred to another department, then wait 6 months or 3 months or whatever it is to be referred to the next one, then wait however long for their surgery, especially when you're looking at something like plastic and reconstructive surgery, where it's semi-elective for a lot of the things that you are getting. I think that seems to be quite discrepant in the experience I've had.
Thank you very much. We are done with the questions you have collected. I'd like to ask the audience if they have any extra questions they'd like to ask the speakers. And if not, we can finalize and possibly end this meeting. Thank you.
Thank you for your question. I think that the answer is not a simple one. I think it's a combination of variables. When you're comparing mortality statistics between countries, you're relying on their reporting being adequate, effective, and timeous. And I think for me, what was very interesting looking at our numbers is they often didn't compare apples with apples. And we were saying, look, South Africa had 10,000 deaths and the UK had 10,000 deaths, or the US had 10,000 deaths. And we kind of said they were the same, but they weren't. Because if you look at the population percentage that died, it's much higher in our setting than in the others. I think there was a false sense of really where we were at. So my key comment is that the reporting in our country, it was underreported. And you could see that by the unexpected deaths that occurred around the COVID pandemic and trying to explain them. And most of those were just because a test was not available or done on the person that had passed away. And so for me, I think it's difficult to compare, and reasons for that are hard to come by because our reporting system in South Africa isn't great. Our information recording system is not great, meaning state everything is written by hand. There's very little electronic record keeping. So I think it's difficult, and you often skew data. So I think those are big challenges about saying whether we've been accurate or not. And that's my opinion.
Thank you very much, Doctor. It doesn't seem like we have any extra questions. So I'd just like to extend a massive thank you to all of you for coming through tonight for this really insightful discussion of the public and private medical sectors. A really special thank you to you, our panel. Thank you all for your opinions, personal experiences, and time this evening. We truly appreciate it, and I hope we've learned something new. I know I certainly have. We hope you all have a lovely rest of your evening and stay safe, and thank you.
Thank you, everyone.
Thank you, everyone.
Okay, thank you. Bye.
Bye.